Hi, this is Michael Altos, and today we're talking about the GI system and antihistamines, and this is part 1. First, we're going to talk about histamine. Histamine is a substance that naturally occurs in the body. Histamine is released as part of the inflammatory response, or when people have an allergic response, and it comes from different cells, like mast cells, which were found in the skin, the lungs, and the GI tract, as well as basophils, which are in the circulation. Histamine binds to several different kinds of receptors. There are H1 receptors, which I think of as the allergy receptor. When histamine binds to the H1 receptor, it causes contraction of smooth muscle in the respiratory and in the GI systems. It causes pruritus, which is itching, and sneezing. It causes release of nitric oxide, and as we know, that causes vasodilation. That's probably why people get flushing and redness when they're having a histamine release. It can have some effects in the heart as well. It can decrease conduction across the AV node, leading to bradycardia, and can cause some coronary vasoconstriction. The second receptor, the H2 receptor, is what I think of as the GI receptor, because its primary effect when histamine binds to the H2 receptor is to cause secretion of gastric acid. There are some effects in the heart as well, maybe increased myocardial contractility, increased heart rate, and coronary vasodilation. And then there's the H3 receptor, which I think of as the negative feedback receptor. The idea is that when the body releases histamine, some of it binds to the H3 receptor and inhibits further release of histamine and synthesis of histamine. There may be some overlap with the H2 receptor, so you have to think about it. If a patient gets an H2 blocker that also blocks H3, then they're going to continue synthesizing more and more histamine, and that would be pretty dangerous, especially if you're also giving drugs that evoke histamine release. What are some of the side effects of histamine? Well, based on what we've described, we expect some cardiac effects. So peripherally, we see flushing and hypotension, decreased systemic vascular resistance, capillary permeability, which leads to edema. And in the heart itself, the sum of all of these different effects usually leads to some positive inotropic and chronotropic effects. So a little bit more heart rate and contractility, and occasionally some dysrhythmias with high levels of histamine. In the lungs, histamine causes bronchoconstriction, and this is especially an issue in patients who have asthma or COPD, and there may be some increased production of mucus as well. In the GI tract, we see constriction of the intestinal smooth muscle. This causes increased bowel activity and diarrhea, as well as increased gastric volume and acidity. So that's what histamine does, and now we're going to think about histamine antagonists, drugs that block the histamine receptor. These might be used to relieve the effects of allergic rhinoconjunctivitis, which is like hay fever, pruritus and urticaria, itching and hives. There may be some protection against bronchospasm as well, and when people have toxicity from a histamine antagonist, it looks a lot like anticholinergic poisoning, with all of those effects, and can even lead to seizure and cardiac dysrhythmias. Histamine antagonists can be selective for certain receptors. So we have H1 antagonists, which are very selective. They have almost no H2 action at all. The first generation H1 antagonists are known to be very sedating. These drugs have a lot of effect on the muscarinic, cholinergic, and serotonin receptors, and the common side effects include somnolence and cognitive impairment, and all of the usual anticholinergic effects, the tachycardia, dry mouth, blurred vision, urinary retention, impotence. And these are side effects we see with common H1 antagonists like diphenhydramine, which is Benadryl. This drug is used as a sedative, as an anti-itching and anti-nausea medication, with a typical dose of anywhere from 12.5 to 50 milligrams IV or orally, and it has a half-life of somewhere between 3 and 9 hours. Drugs like Benadryl are used to block histamine-mediated vasodilation during anaphylactic reactions as well, and we do see a lot of sedation and anticholinergic side effects with this drug. Other H1 antagonists include chlorpheniramine, which is chlortrimeton, and brompheniramine, which is Dimetapp. These drugs have a lot less anticholinergic side effects, and sometimes people will describe significant paradoxical CNS stimulation, and people won't be able to sleep, and we see this especially in children. Another H1 antagonist is hydroxyzine, called Vistaril, and people have used this for sedation or anxiety, to treat motion sickness and vertigo and other nausea and vomiting. And this drug, again, has a lot of anticholinergic effects. The second generation H1 antagonists are much less sedating, probably because they don't cross the blood-brain barrier. And so we see a lot less of those muscarinic, cholinergic, and serotonin receptor effects. The most common examples of these drugs are loratadine, which is Claritin, and fexofenadine, which is Allegra. We're going to stop here with this recording. Let me know if you have any questions, and we'll pick up again with the next video.